We are live.
Good evening, everyone. So, welcome to another episode of DOS-PEP. And as I am getting a lot of response in my WhatsApp, you people are liking this Strabismus module a lot. Thank you to all our speaker. And today again, another difficult but very interesting topic that will be covered. And this is not only important for your Viva, long cases, theory, but a lot of questions in your senior residency also do come from these topics. And we have a wonderful speaker for that, Dr. Jitendra Jethani. And I request Dr. Pranita Sai to introduce our speakers for today, and then we'll move on to the lecture.
Thank you, sir. So today we are on the 52nd lecture of DOS-PEP in the 7th class for Strabismus module. And as sir has already discussed, we are going to be talking about vertical deviations, DVD, Brown syndrome, and inferior oblique overactions. And we have an eminent speaker, Dr. Jitendra Numal Jethani, with us to be talking about this important topic. Our moderators for the session would be Dr. Gunjan Saluja and Dr. Anita Gangar ma'am. Dr. Jitendra Jethani, sir, he's done his MD, DNB, FNB, and FAICU and PhD in myopia. He is the director of Baroda Children Eye Care Center and Squint Clinic, and also a part of the Orthoptics Incorporation and Myopia Control Clinic and Research Center and ROP clinics. He is the ex-secretary and president of Baroda Ophthalmic Society and ex-scientific committee chairman of Gujarat Ophthalmic Society and ex-editor of the Indian Journal of Pediatric Ophthalmology and Strabismus. He has received various awards for his presentations and publications and has over 67 peer-reviewed indexed articles to his credit. And his main area of interest is strabismus, pediatric ophthalmology, myopia, and vision therapy. With that, sir, I would like you to welcome to our series of DOS-PEP lectures, and the dais is all yours for the presentation.
Thank you. Thank you so much, Dr. Pranita, and thank you, Dr. Praful, for this invite. Okay, are my slides visible and I am audible, right?
Yes, sir.
Good. Okay. So, we would be talking about vertical strabismus, and so the whole lecture will be like that. We will talk about vertical strabismus, little bit about what could be the differential diagnosis. I have not been able to cover loud into horizontal strabismus with vertical strabismus, lot of committant strabismus. My basic, my whole thought process or my whole point is to talk about dissociated vertical deviation. So I have not talked much on dissociated horizontal deviation, Brown syndrome, and infraoblique overaction. And if it is permissible, we will talk more about, committant vertical strabismus. We will talk more about blowout fractures, Graves' thyroid orbitopathy, like other causes, monocular elevation deficit, and all those causes of vertical strabismus in next class or in another class. So this is just a small photograph to talk, to give a perspective about what we will be taking care of, what is vertical strabismus. And these are a few things which we will be seeing in our discussion. So these are the differentials of vertical strabismus. You can have committant deviation, incommittant deviation. You can have congenital incommittant deviations. Specifically, the Browns should not be at the top, but because our topic of discussion is Brown syndrome and dissociated vertical deviation, so these are not very common things, but yes, because they are the topic of interest today, they have been posted above. Most common is, of course, you will have horizontal deviation with some amount of committant vertical deviation. And sometimes, we try to club infraoblique overaction as a committant deviation. It is not really a committant deviation, but it is the horizontal deviation which is committant. And so we take infraoblique overaction as a incommittancy in the committant horizontal deviation. So, and then we come to the incommittant acquired vertical strabismus, which can be because of thyroid orbitopathy, some infections, Q deviation, and third and fourth nerve palsy, which are obviously separate large topics, and would love to cover that. But some small baseline on what should be our vertical, what should be our investigation. So if they are, you have to measure the deviation. If they are acquired, acute, acquired, you have to do diplopia chart, Hess chart, neuroimaging. Hess chart in itself has evolved over a period of time, and now there are new Hess charts, new techniques of Hess charts, which are mainly computerized, and these are good techniques because they also give you fixing right eye, fixing left eye, computerized. So this was 9 gaze coming out. It has made things easier for for general ophthalmologists or students, because they try to shy away from measuring each eye into various gaze positions. So neuroimaging should be done if you suspect that this is acquired, and any acquired vertical deviation you should consider neuro imaging. Always try to look for torsion. Either you can do a double Maddox rod, which is a subjective test, or you can take a fundus photograph and measure disc foveal angle, as I'm showing in this picture. You should always do a head tilt test. The only reason why I'm not elaborating on head tilt test is because we will be talking more on DVD infraoblique overactions and less on supraoblique palsy. But head tilt test is a very good test. It straightforward tells you it's a good test for single muscle pathology. It's a good test if you want to find out there is a supraoblique underaction or supraoblique palsy or not. So it's a good test. You should do more or less in all the patients of vertical deviation if you feel that the vertical deviation is incompetent in gaze positions. So let us take the first topic, that is dissociated vertical deviation. Now, normally we know that any deviation in the eyes or any movement in the eyes would hold Haring's law of equal innervation, and we have to see whether this particular this particular deviation is truly holding Haring's law of equal innervation or not. So these are, if we take a small schematic diagram of two eyes, the elevators have been shown as right superrectus and right infraoblique, and in the left eye, left infraoblique, left superrectus, and the depressors are right infrarectus and right supraoblique. And when you look towards above or supraduction movement or elevation, you will have these muscles which will contract. And so these are the yoke muscles for elevation, where right superrectus is yoked with left infraoblique and right infraoblique is yoked with left superior rectus. And these are the yoke muscles for down gaze. Now, if this is a child, he has a small right esotropia. When you look from Hirschberg, or when you look as a when the patient walks into your clinic, what child is showing is that there is right hyper of 20 degrees. Suppose this is the schematic diagram. When the patient looks down, the left eye moves down by 20 degrees and right eye also comes down. When you cover the left eye, the right eye moves down, takes up the fixation at 20 degrees down, and left eye moves down further. So there is a contralateral hypotropia in the left eye when right eye is fixing, right? Now, if you have a patient where right eye hypertropia is there when left eye is fixing, and when patient tries to fix with the right eye obviously comes from up to down, but left eye position remains unchanged, which means that there is no left eye hypotropia. Now, this is a clear deviation from Haring's law of equal innervation. So the yoke muscles are not working. So if the vertical muscles of two eyes are not yoked together, Haring's law does not hold. And normally the result would be a dissociated vertical deviation. As you see in this particular picture, the right eye is up. And when you cover the left eye, right eye takes up the fixation. And when you uncover the left eye is still down. So this is following the Haring's law of equal innervation. The muscles are yoked. Both the eyes go down simultaneously. Whereas, so this is true hypertropia. And when the patient is looking with the left eye, right eye is up in this picture. And when you look towards the right picture, it is the right eye which is fixing and left eye is hypertropic. So this is, what is this? This is bilateral DVD, and none of the eye is showing hypotropia. The eye is not going down. Now, why does this occur? So why it is not following Haring's law of equal innervation, whereas in most of the cases, it has to follow Haring's law of equal innervation. Now, there has been a lot of debate, a lot of thought process in what exactly is wrong or what exactly is the problem in these particular cases. Now, there are two schools of thought. One is the Brodsky school of thought. And what he thinks is that it is the dorsal light reflex, which is actually the lightning reflex in fish and in primates. So what happens in fish and other lateral-eyed animals is that, they have to, they really don't have a true fovea. And so the dorsal light reflex is basically a reflex which helps them by correcting them. So the fish has to travel under the water, and if you tilt the bowl, if the fish is in a bowl and the water level becomes horizontal, then fish has to correct itself with the level of the water. Now, this particular reflex helps the dorsal or the top part of the fish towards the primary light. The light is coming from above. So helping it will help it stay upright in the water column. Now, this mechanism involves balancing the visual input between the two eyes. And so the eye which is receiving less light. So if you tilt the bowl, the light will come from one side and the other side, the light will be less. And so it is basically the rightening reflex in the fish. Now, these are what are the Brodsky's thought about it. How does it activate the primitive reflex? Now, when this particular asymmetric visual input, now what Brodsky thinks is that probably these particular reflexes of dorsal light reflex remains preserved in some of these patients who develop who develop loss of binocularity or loss of strabismus or presence of strabismus very early in their life. So what happens is, in humans, this generates a wrong response. Why wrong response? Because unlike in fish, basically humans are already, their foveas are developed, and so they don't need this particular dorsal light reflex to correct their posture. Now, in humans, we have a dominant visual pathway. We have a foveal driven vision because we are standing on our hind limbs, and our brain is trained to align the fovea over the object of interest in the environment. And it is not because of the peripheral light, it is because of the central light. And because of this, and because of the vestibular dominance, what happens is that this particular reflex is suppressed in humans, but in some patients, this particular reflex, which is actually a rightening reflex, has gone away. And this can happen if there is a very early strabismus. In cases of early strabismus, this may come up. Now, there is another school of thought, which is Guyton's school of thought, where they believe that it is actually, if you see all these DVD patients, you would see that they are always associated with a small latent nystagmus when you cover the fixing eye. Now, when you're covering the fixing eye, there is a small latent nystagmus, and Guyton and co-workers believe that when this particular eye, which is having a latent nystagmus, when it starts moving upward, it suppresses or compensates for that nystagmus. But because when they are trying to compensate for that nystagmus, the eye goes up and tries to go outward and slightly excyclotorts. So this is the a mechanism, according to them, that it blocks the nystagmus, but there is a trade-off, which is in the sense of moving the eye upward. So those are the two. This is just a small comparison, between dissociated vertical deviation and infraoblique overaction. But these two theories at this point of time hold promise. And most of DVD is explained as to why it happens, because we are always curious about why dissociated vertical deviation happens, why it is not really following the Haring's law of equal innervation. Now, this slide is very important from our postgraduate level, because normally in exams they would ask a question that how do you differentiate between a vertical deviation which is dissociated vertical deviation. Typically, how do you differentiate from infraoblique overaction? So these are some differences between the two. And most common is that infraoblique overaction will have a V pattern. Infraoblique overaction will show an X cyclotorsion. Infraoblique overaction would increase in adduction, whereas DVD may increase in abduction. But yes, you may have patients who have dissociated vertical deviation along with infraoblique overaction. So both may coexist, but it is possible that DVD may exist even with superoblique overaction. And we will see some of the patients where it is existing with superoblique overaction and there is a pattern. So I think torsion is also very, very important, and we should not overlook torsion in dissociated vertical deviation patients. Normally, they will not follow a Hering's law. They will have a small horizontal component. Normally, they will have a torsional component. There will be an associated latent nystagmus. You would usually see that there is an early onset strabismus and there will be a hypertropia, which does not have a hypotropia in the other eye. Now, normally, to see what is going on, you can use a Spearman occluder. This particular occluder, what it does is it dissociates the eyes. As you can see that this particular patient has left eye, which is elevated here, and when we cover the right eye, the left eye comes in the center, and there is no hypotropia in the right eye. So that is very, very crucial of DVD. Another important test which was described in 1992, and again it was described in 2001. They sort of expanded on that, was by Michael Graf, where they tried to talk about a reverse fixation test. Basically, this is to diagnose dissociated horizontal deviation, which is the horizontal component of dissociated vertical deviation. So basically, deviation along with vertical deviation, there is an associated horizontal deviation also. Now, what they are trying to do here is, if you see this, this is the fixing eye, and they have put the prism in front of the non-fixing eye. When they cover the fixing eye, this particular eye is already neutralized. But what has happened is there is a small isotonus, there is a small iso deviation in this particular eye, which is under the cover. Now, this particular point is known as the reverse fixation, because once you neutralize this eye, there may be a reverse fixation. The eye may have an isotonus, and this also you can measure back. So this is what is known as reverse fixation test, when fixing right eye, fixing left eye. So what reverse fixation test is revealing is that, the refixation movement in the final step. As I said, that once you attain fixation here, with this you have neutralized at 40 prism. It represents basically the difference in the amount of isotonus that is generated by monoocular fixation. So it is the isotonus of this particular eye which is at fault according to Michael Graf and his colleagues, and the direction of movement is equal and opposite in both the eyes. Normally, the eye in intermittent exotropia or in committant exotropia, both the eyes will come from out to in. Whereas in this particular case, the eye may have an isotonus. You will see that eye may be coming from in to out. So that particular point is important when you are measuring dissociated horizontal deviation and looking for reverse fixation. Now, when to intervene in DVD, that is very, very important. Unilateral DVD, if it is significant and if it is manifest. You can always give a trial of switch fixation where the dominant eye has to be blurred to suppress the DVD if there is unilateral DVD. Symmetric DVD, if it is significant, you have to operate. Associated with significant horizontal deviation, if you are going to manage the horizontal deviation, you might as well look out and do something for DVD also. And again, if it is significant, if it is cosmetically manifest DVD, you can go for surgery. Now, these are some of the patients where you can, see, this is one patient. Now, this was a patient who had both vertical and horizontal deviation. What we have to see here is that when he's fixing with right eye, the left eye comes from up to down. But when he fixes with left eye, the right eye only comes from out to in. Now, we have, like in reverse fixation test, we are first trying to neutralize the right eye and then the left eye. And these are the measurements that we had. Now, once you neutralize the left eye horizontal deviation, you have to start measuring the vertical deviation. And you would notice that right eye, instead of coming from down to up, once the left eye is neutralized, it starts going up. So there is no corresponding hypotropia in the right eye. In fact, there is a hypertropia in the right eye, even when left eye is not completely neutralized. Now, what we did was, we did both eye lateral rectus, and we also did both eye superior rectus surgery. The numbers I will show, but this is what we did. So in DVD, normally you will not have complete orthotropia, some amount of deviation, because it is a completely moving target. You have absolutely no clue whether you want to correct fixing right eye or fixing left eye. So how do you decide? Basically, what you do is you try to take the fixing eye, the dominant eye, and try to correct the amount of deviation in the non-dominant eye. However, you have to be very, very careful. And as I said, there is a small minimal ISO and a small hyper. You can see for the small torsional movement also. This is after a month. So this is with Spielman occluder. We are trying to show that there is still a small left hyper and there is a small left eye. If he's fixing with left eye, you see post-op he was right eye was small ESO, but now he is a very small exo. So the drift of eye has taken place slightly outward. So that was one patient. And now let us see another patient. This is another patient where we have dissociated vertical deviation with horizontal deviation, and patient doesn't have infraoblique overaction. In fact, patient has a supraoblique overaction. So when she is fixing with left eye, you can see the right eye comes from up to down, and when she is fixing with right eye, left eye goes up. Now we are trying to neutralize the deviation. You can still see that we have neutralized the horizontal deviation. Now we have to stack up horizontal and vertical prism. We have added a prism in front of right eye. Whatever deviation you see in left eye is the part of reverse fixation test. So now we have neutralized the right eye. The left eye is coming from up to down and right eye is neutral. We will see the ocular motility also. Now we are trying to take fixing right eye measurement. So the most important part here is that we have to take fixing right eye, fixing left eye measurements. When you are putting prism in front of left eye, you are measuring fixing right eye. When you are putting prism in front of right eye, you are measuring fixing left eye. So whichever eye does not have prism is the fixing eye. Now these are the numbers that we found from this patient. Now this patient doesn't. This patient has the supraoblique overaction. Yeah. Okay. So now we are trying to again neutralize same thing. Fixing right eye. We are trying to first neutralize the horizontal deviation, and then we have given a target. Here it is tip of a pen. And then we are trying to neutralize fixing left eye. And once now you see we have stacked up the prism fixing left eye. There is hyper, but there was no corresponding hypo in the left eye. I think this was a patient who had bilateral. No, I don't think so. Okay. This is a patient. There is another patient. Recently, I think we saw her. Yeah. Okay. This is fixing right eye. We have measured left eye. And now we are taking fixing left eye. You see there is no correct. We have slowed down the movement just to show you the ocular motility. See, both the eyes have hyperdeviation and she is still, there's a small fixing left eye. I think it around 14 prisms. And then we are measuring fixing left eye. We are measuring the right hyper. Yeah, you can see she's fixing with the left eye. And with the left eye, it is 16 prisms base in, that is for exo, and 8 prisms base down in front of right eye. So this is fixing left eye. We have measured the amount of deviation in right eye. Now we are measuring fixing right eye. We have stacked up the prisms. See, right eye goes into esotropia. That is what is part of reverse fixation test. It is 25 prisms base in and 10 prisms left eye base down. So that is fixing right eye. This is right eye infraoblique overaction. You can see that there is just for clarification, we are trying to show that she has both eyes infraoblique overaction and she has a V pattern also. Yeah. Yeah, you can see that left eye goes out. there is a right eye infraoblique overaction. See, the sclera is visible here and it is not here. You can easily see that eye is going up, and same thing is there in the left eye also. Yeah, when I cover this, she starts fixing with right eye. Now the left eye is gone up. This is post-operatively. We are trying to use a Spielman occluder just to show that the eye is not going up. I don't think Spielman is helping much, but she still has a small hyper in right eye, and small exo is still there. So this is post-surgery. We don't want to overcorrect because these are very small angles, small numbers. So I think we have done only one horizontal muscle in the left eye, and both eyes infraoblique anterior transposition. So we'll see how we did transpositions, but that was regarding bilateral infraoblique surgery for DVD. So surgical procedure of choice completely depends on what is, what exactly patient has. If there is purely, there is no infraoblique overaction, we have to do recession of superior rectus. And these recessions are normally larger recessions. If you go to point number 4, they are unconventionally large recessions, and they are not like 4 millimeter or 5 millimeter. If you have to do larger than this, you should add a posterior fixation suture and anterior displacement of infraoblique insertion, which is anteriorization, which we did. And we will see in infraoblique overaction how we can do infraoblique anteriorization. And so you can do recession of superior rectus. Rarely you can combine it with resection of inferior rectus. If there is infraoblique overaction, you can go ahead and do infraoblique anterior transposition. If you are doing infraoblique anterior transposition, try to do it bilateral. Unilocular anterior transpositions may end up having anti-elevation syndrome. We will talk about that also. Now, if there is associated horizontal deviation, don't plan an overcorrection like we plan in intermittent exotropia, because you have to remember that DVD is mainly about unequal isotonus, and patient may never recover completely from that overcorrection. And unilateral DVD patient may end up showing DVD in unoperated eye, which means that once you operate the eye which is having DVD, it is possible that patient may switch fixation post-op and start showing DVD in other eye. So you should be prepared about it. And if there is an associated supraoblique overaction, you should also tackle supraoblique along with DVD. These are some gross numbers, what can be done. I think what happens is that numbers change and numbers are different for different people. So they're just a gross numbers that we can follow. And so this is how you do infraoblique anterior transposition, but never try to spread this particular thing. We will talk about it again in infraoblique part, but never try to spread out the muscle. As much as possible, try to bunch the muscle. If you are doing anterior transposition, try to do it bilaterally if you are going to do it. And so this is what about bilateral DVD. Very large recessions you can do. Bilateral infraoblique anterior transpositions can be done. So that brings us to the end of dissociated vertical deviation. We have not covered dissociated horizontal deviation or anything except the vertical part of it. So we move on to the infraoblique surgeries. So what are the indications for infraoblique surgery? Now, and before we move on to indications, we should see these videos to know what exactly is infraoblique overaction. Pardon the music, yeah. So the infraoblique, as you can see, I could not slow down the motility. You see in down gaze there is no exo, in up gaze there is a large exo. This is okay, we'll go back. I'll just pause it where I see infraoblique overaction, and we will talk about how to detect infraoblique overaction. So you see, when patient looks on the right gaze, yeah, you see this particular eye is fixing and this particular eye is elevated. So this is showing left eye infraoblique overaction in this eye. Also, when he looks on the right side, on the levo version, you will see that the right eye will move up And so if this is what is happening, where he is still fixing with right eye and left eye is going down, as I had shown you in my video, you can put a block between the two eyes, you can cover this particular eye and let this eye fix, and then this eye will move up. This would happen if you see this. This is definitely bilateral infraoblique overaction. More importantly, what we should do here is that we should try to make sure that we are able to differentiate between bilateral infraoblique overaction and unilateral infraoblique overaction. Similarly, if you see this particular patient, this is this elevation is infraoblique overaction, and if I go back, he's fixing with left eye, this eye is going up, and if this eye doesn't go up, yes. So this is how you can grade infraoblique overaction. The grading system is not very useful, but yes, +1 is minimal up, and +4 is 90 degrees or at least 70 to 80 degrees. So that is how grading works. And if you see this particular patient, she has a large infraoblique overaction, and the reason why I'm showing you this video is because she has a unilateral infraoblique overaction. She actually has if you can see, there is a small plagiocephaly. That is not the topic. We will not deviate from it. But if you can see, she has a V pattern. In up gaze, there is a larger exo compared to down gaze, but she also has a primary hyper in right eye. Now, sometimes when you have primary hyper in the right eye, the problem is that it becomes difficult to differentiate whether it is infraoblique overaction or it is really, a primary hyper which you are seeing there. Yeah. So I thought, okay. So this is what I was trying to show. If you see this, I have slowed down the video here. Yeah. If you can see this, the right eye is completely up. If you have a doubt here, what you can do is you can measure the deviation in levo version and in dextro version. And if there is an angle which has increased in the levo version, then if the L by R or R by L has increased, then it is definitely an infraoblique overaction. So this was a patient who had, who had this particular skull is flat, and this is some other reason for infraoblique overaction. So these are some of the indications. If there is an overaction of infraoblique, we should try to weaken it. And these are some of the contraindications where infraoblique is not really the culprit for elevation in adduction, and so we should avoid touching infraoblique. Now, infraoblique is actually a wonderful muscle. It has the shortest tendon, shortest course. It is very forgiving muscle. And this is taken from David Pleasure. And, this is how they talk about how do you weaken the infraoblique. And you cannot weaken it beyond 12 millimeters. And so if you have to weaken it beyond that, you have to go you have to go on the nasal aspect of inferior rectus to further weaken it. So this is where the author is trying to show the vortex vein. This is the neurovascular bundle, and this is the scheme of how much how much interiorization you can do, and this is the scheme how much recession you will get out of infraoblique recession, and how much recession would be in equivalent to 6 millimeter, 8 millimeter, 10 millimeter, and 14 millimeter recession. Infraoblique, yeah, these are some of the some of the ways by which you can weaken infraoblique. So point A is actually the origin, and point B is actually, this is the place where it gets inserted. This is lateral rectus, this is inferior rectus. You can see infraoblique anterior point. That is around 10 millimeters from lateral rectus insertion, which is 6.5 millimeter from the limbus. And these are different authors who have suggested different ways of recessing the infraoblique. H is the vortex vein, and C is the fink, which is 6 millimeter posterior and 6 millimeter inferior, which will give you around 8 millimeter of recession. The names are important because we will be talking about them when we will be talking about how to weaken infraoblique. And so since there are too many surgeries, which surgery to do for which muscle and how do you select? So you can select based on the fact that, there are some surgeries which give you only pure recession effect. There are some surgeries which give you recession with enterization. So pure recession surgeries are Fink's recession and graded recession of apt and call. Recession with anterior positioning is mainly Park's recession, which gives you 10 millimeter of recession and some enterization. Pure enterization is anterior transposition, where which is Elliott and Nankin and modified Elliott and Nankin, and then there is enterization with nasalization, which typically also gives you some intorsion effect and prevents anti-elevation. So what oblique muscle surgery is doing is it is affecting the globe position vertically. It is affecting the globe position in primary and secondary deviation. So vertical amount of deviation in primary may not be affected much if you are doing pure recession and recession with enterization. But it may affect vertical in primary position a lot if you are doing enterization, which is total anterior positioning, or enterization with nasalization. And it will be very, very effective in secondary position, because when you have infraoblique overaction, in the secondary position, it is most effective, whether it is pure recession or recession with enterization. So based on few things, I personally decide. And when there is a very minimal infraoblique overaction, how do you even know that there is an infraoblique overaction? What we do is we try to see if there is any V pattern or not. We try to see if there is any torsion or not. You can do Fink's recession, which is typically 6 millimeter posterior and 6 millimeter inferior to lateral rectus insertion. And this is a small video just to show you that what we are doing. This is we are holding the lateral rectus. We are going 6 millimeter posterior and 6 millimeter inferior. So this is 6 millimeter posterior, and then we are going 6 millimeter inferior. I'm not going into the details of how to hook the infraoblique. This is only about talking about the techniques of how to weaken the infraoblique overacting muscles. So this is the first point, and the next point can be 2 to 3 millimeters posterior to this in line of infraoblique. As normally the inferior oblique will be obliquely placed, you can place the suture similarly. Now in moderate overaction, that is +2, with V pattern, you can do a graded recession. Now, how do you do a graded recession? Basically, these are pure recessions. So we assume that there is no hyper in primary. So if there is no hyper in primary, you can do a graded recession. How do you do graded recession? You basically go via inferior rectus. You go 3 or 4 millimeters. This is 10. This is 12 millimeters of infraoblique recession. We have gone 4 millimeter inferior from inferior rectus and 0.4 to 1 millimeter temporal to inferior rectus. So that gives us an effect of around 12 millimeters of infraoblique recession. And then if there is large hyper in primary, we can do a modified Elliott Nankin. If we have a hyper which is around 6 to 10, we can do a Park's recession. And if there is a very small hyper in primary, we can still go with the same graded recession, that is apt and call. So what do you do if there is a large hyper in primary? You actually do total enterization, which means that if the angle is more than 10 to 14 presents, you place it right next to inferior rectus, or you can place it 1 millimeter inferior, depending on how much is the angle. And for Park's recession, no, this is not Park's recession. Yeah, this is Park's recession. Basically, what you do is you go 3 millimeters inferior and 2 millimeters temporal. Oh, yeah, we have hooked the inferior oblique, and we are just trying to show the triangle, which clearly shows the sclera, which shows that we have hooked the inferior oblique completely. So once you hook the inferior oblique muscle, you take you can take a artery forceps, clamp it, or you can take a muscle clamp. Then you can we try to cut the muscle before, and then try to suture the muscle once we have removed it from its insertion, because that way you can be close to the insertion as much as possible. This is how we are. I'm just trying to show that, once this photograph has been taken from Dr. Ed Buckley's atlas, but we are trying to show that, once you take the muscle, you can pass two sutures from it, and you can put it for Park's point. You have to go 3 millimeter inferior and 2 millimeters temporal to inferior rectus. So this is that point. And as I said, you don't have to really enlarge the new insertion. You have to bunch the muscle. So you have to be very close. You have to bunch the muscle, and you have to be very close. The next suture has to be 0.5 to 1 millimeter temporal to that. So this is inferior rectus. This is 3 millimeters, and this is 2 millimeters. I think we can move with this. Yeah, this is basically the technique to do nasal enterization when you have very large hypertropia, and you want to do it for prevent anti-elevation syndrome. Basically, you have taken the infraoblique, which was inserted here. You have taken it out and put it 2 millimeter inferior and 2 millimeters temporal to the inferior rectus, and infraoblique is underneath the inferior rectus. We'll skip this. Yeah. So should I continue, or Dr. Gunjan?
Yes, sir, you can continue. Please complete the topic. We have time.
Okay. So Brown syndrome was, actually described way back in 1950s. And if we go back into the literature, we would see that this was typically thought to have it was basically thought that it was the sheath in which the supraoblique tendon is there. And it was thought that it was the tendon sheath syndrome, because what Brown's thought was that probably it was the tendon sheath which was not letting the supraoblique glide properly inside that. So initially, he did propose that, surgery should be done. And in his later papers, he did say that, there were a lot of patients who did not undergo surgery and improved spontaneously. So that those two articles did change a lot of thought process as to how we should manage Brown syndrome. So, but what is Brown syndrome? Brown syndrome is typically inability to elevate the eye in adducted position, both actively as well as passively on forced suction. And we will see a couple of even acquired Browns can occur because of supraoblique surgery. If you have done a tuck, it is secondary Brown. Could be because of scleral buckling surgery, glaucoma wall surgery. Basically, it is the superior oblique which is not letting the globe go up. So supraoblique has become tight and it is not letting the globe go up. It could be because of inflammation, could be because of rheumatoid. These are all acquired reasons for Brown syndrome. Could be Graves' orbitopathy, SLE, could be blunt trauma or direct trauma. So what is true Brown syndrome? When it is a typical Brown syndrome without coexisting limitation of ipsilateral superior rectus muscle. So it is purely the superior oblique which is at a problem, and it is atypical with significant limitation of superior rectus muscle also. So if you see this particular child, you will see that when she's trying to look in the levo version here, yeah, we'll just hang on there. Yeah, all the features she has. She's a very classic. Yeah. So if you see this, she is ortho in primary position. She's good with primary position. When she tries to look on the left, the right eye is not able to elevate. And the right eye, you can see that it is going inside also. There is she's not able to elevate, as well as the globe is also retracting a little bit. When she looks up, there is actually a V pattern. So normally, supraoblique overaction will create an A pattern, but in Brown, supraoblique will create a V pattern, because when the patient is trying to look up, the supraoblique overaction does not occur, but superior oblique is very tight and it is not letting the globe go up. And so when the patient comes slightly in the primary position, when the patient tries to look up, the superior oblique sort of slips and the globe completely goes out. So this particular patient, if she is orthotropic in primary position, we don't really want to touch the patient. Now, this is another patient. If you see this patient, you can see I've made an arrow. In primary position, she has right hyper because actually the left eye was showing the fixation. But if right eye is taking up the fixation, there is no hypotropia here. This is slightly in adduction that the globe is not able to move up. You can see that superior rectus is untouched. The superior movement of left eye in abduction is completely normal, but in primary position, it is not there. Down gaze is normal. And if you see in this particular position also, the globe is not able to move up. So it is very, very important to see what patient has in primary position. In this particular patient, you see patient has esotropia in primary position. So if you are going to, if patient is symptomatic in primary position, if patient has chin elevation, patient has another coexisting horizontal deviation, if patient is having some strabismus which is manifest, or patient is having amblyopia, it means that patient is having a problem. This is another case of Brown's, but it is bilateral. So how do you grade Brown's? So mild is when there is restricted elevation in adduction, but there is no hypotropia or downshoot in adduction. Moderate is when there is restricted elevation and downshoot in adduction and no hypotropia in primary position. And severe is when you can actually see a hypotropia in primary position. So normally we don't want to operate these patients if there is nothing significant in primary position. Now, how do you do FDT and how FDT is different from a normal force duction test? So force duction test in these particular cases would be exaggerated force duction test. And there are two principal points in exaggerated force duction test. One is you have to retroplace the globe, which means that you have to push the globe down so that supraoblique becomes stretched. Once the supraoblique is stretched, what you do is you manipulate it torsionally so that you can hear the click. This is inferior, this is lateral. You hold it from inferior and superior part and try to rotate the globe after retropulsing the globe. Now, the associated features can be downshoot or hypotropia and adduction. Widening, this we already saw. And these are the differentials. So obviously, if it is an acquired case, you have to wait. You can give steroids. You can give local triamcinolone also injected directly in the area of trochlea after doing neuroimaging. And you can also go for systemic treatment of underlying, autoimmune or inflammatory disease. And the surgical management in congenital case is always about what is there in primary position. Otherwise, wait and watch is a good thing. If there is hypotropia in primary position, we call it Brown's plus syndrome, Brown syndrome plus. If there is anomalous head posture, if there is an unacceptable downshoot in adduction, which is moderate Brown syndrome. Now, there are different surgeries described. Tinectomy, normally we do not really favor tinectomy. Now, there has been a thought process about supraoblique tinectomy with infraoblique recession. I have not done that much because I feel that you are weakening both the muscles. So yes, we do a lot of supraoblique split lengthening. So what you do here in supraoblique split lengthening is that you create a split in the supraoblique, and these two arms of the split you can suture them together. And another great surgery which was described by Kenneth Wright was silicone expander, which is a lot of people do silicone expanders. And so what you basically do is, since we know that it is the supraoblique which is tight and it is the limitation created because of the tight supraoblique, a silicone band is used, the same silicone band which is used in buckling procedures. Basically, you cut the two ends of supraoblique and implant a silicone expander. Similarly, instead of silicone expander, you can use a non-absorbable suture, and then we call it a chicken suture. So you can use both the things, and you can elongate the supraoblique muscle and thereby weaken the supraoblique muscle. The grading is depending on how long a silicone band you want to leave. And I've not included the video of both these things. And these are some other reasons for restrictive strabismus. And so that was regarding DVD. infraoblique overaction, and Brown syndrome. So thank you so much. I know I sort of rushed in the end, but I thought we should stick to time.
But sorry sir, हमने आपको इतना बड़ा major topic दे दिया.
नहीं, actually
That was
क्या है,
really
all the
good.
3 topics are separate lectures of 1 hour. So you can see the background of the slide changing because these are different lectures which I sort of hidden slides, and I tried to push them into a single presentation.
Sir, because of sir, this is what we are doing henceforth. I hope you are okay with that. What we have started, sir, we are sending the PDF of PPTs,
Okay.
to the students, so that at least they can revise whatever being taught to you. I
Yeah.
hope you won't mind in sharing your
No, I don't mind.
PDF or
We
PPT.
can send that. I will send you the PowerPoint presentation.
That's great, sir. No, I'll you can send it to my email, or even you
Yes.
can put it in that WhatsApp group. I think we have
Sure.
included you in that speakers
Yes,
group.
yes. I'm
Yeah,
part
you
of it.
can
Yes.
put it there. And I guess Gunjan and Pranita, do you have any questions?
Yes. Thank you, sir, for the wonderful lecture. You have covered all the points in great details of these 3 vast topics. So someone is asking about what is Brown's plus syndrome.
No, I could mention it in the end that Brown's plus would be hypotropia in the primary position. So that would be Brown's plus.
Yes, so I think that is Brown syndrome with superior oblique overaction that is associated.
Yes.
So that is Brown's plus. And then is canine tooth syndrome different from Brown syndrome, or is it the same? Canine tooth syndrome.
So the canine tooth syndrome is actually what is happening is that so initially canine tooth syndrome was taken in Naps and Moore classification. It was type 6 Naps and Moore classification of supraoblique underaction. But what happens is that basically what is happening here is that the canine directly goes for the eyes, and once once he bites the person, he basically injures the trochlea. So it can behave like a Brown syndrome, acquired Brown syndrome.
Yes. So basically, it is after a dog bite or canine
Yes.
bite that the trochlea is damaged, as sir has very well explained. Then someone is asking about the chicken neck lengthening suture technique for management of Browns.
Yeah, so chicken suture is similar to silicone expander, except that instead of using a silicone band 240, which we use for retinal detachment surgery, we are using non-absorbable sutures of the same length.
Yes. So definitely it does have some advantage over the silicone expanders because silicone expanders can get infected or extruded over time, but the non-absorbable.
The difference, so the difference between the two is that silicone expander is a good technique because the muscle, the 2 parts of the muscle are tied on the silicone expander. Whereas in chicken suture, the gap is still there. So there are 2 problems. Either the 2 ends of the muscle may get stuck on the sclera, or they may come closer to each other. So each has its advantage. And gradually surgeons tend to deviate towards a particular type of surgery which works for them.
Yes. So one more thing for DVD, someone is asking, is inferior rectus plication a good option?
It's a good
Because
option.
someone was having their thesis, so they are asking.
Yes. So it came up, I think, 8-10 years back that in some of the patients, I think there's a publication by Jyoti also on that. Inferior rectus plication came up as another alternative. And so normally inferior rectus plication is once you have already done or exhausted your resources in terms of doing superior rectus. But yes, there are recent articles on inferior rectus plication as another alternative for elevation of eye. So yes.
Yeah. And then one question is, what is the difference between inferior oblique overaction and upshoots in Duane's retraction syndrome?
Oh, yes. So there are a few important points here. It would take a minute. So if you see infraoblique overaction, it would not be abrupt because it is at the end of the day, infraoblique is also having a saccade, whereas in upshoot and downshoot, it is the slippage of lateral rectus which is causing the upshoot. So when you tell the patient to adduct the eye, it is the lateral rectus which is slipping. So there will be a sudden elevation along with retraction of the globe. Whereas in infraoblique, you will not see that. In infraoblique overaction, you will have an excyclotorsion. Not in all patients, but you would definitely see an excyclotorsion, which would not be there in Duane's retraction syndrome, which has upshoot. Also in Duane's retraction syndrome, you will see a you will also see a downshoot in the same patient. If it is a mechanical DRS, which is more common. So if there is a downshoot, it clearly rules out infraoblique overaction. So whenever you see an upshoot in DRS, try to always look for a downshoot also.
Yes, and plus there might be co-contractions also in Duane's retraction syndrome that
yes,
could
yes.
be
There will be a
associated.
co-contraction. That is what is
Yes.
causing the slippage of lateral rectus.
Yes. So another thing, sir, that I would like to add is you had shown very beautiful videos of DVD with superior oblique overaction. So the other name for that syndrome that postgraduates should know, Helveston syndrome. And I think A pattern can be associated with it instead of B
it is
pattern.
associated, but I did not mention Helveston syndrome because Helveston syndrome typically is exo with DVD. So you are absolutely right. It is Helveston syndrome, but normally when we, it is exo with DVD with A pattern. So I don't, I didn't want to really confuse that another syndrome has been added.
Yeah, because these are questions which are
They are
asked as MCQs to them.
Yes.
So I think that covers the topic in great details you have covered. Thank you, sir.
Thank you.
Thank you, Gunjan, and thank you, sir. And I think Pranita, will you be sharing that thing? Yes. Yes, sir. This is a small appreciation from DOS, sir, for you.
Thank you.
And we are doing, sir, our winter DOS conference in October 11-12 and annual DOS in April 24 to 26 next year. So if you could please join us, then we'll give you a frame certificate of this.
Sure, sir. Sure, we'll do that.
And with this, I think, Pranita, we can conclude.
Yes, thank you so much, sir, for taking out your valuable time preparing that extensive
Pranita's voice is
presentation with the
breaking.
beautiful videos. And I think the student must have benefited. Okay, sir. I think with that, we can close the class. Thank you so much, sir, for all your valuable time. Thank you, sir.
Thank you, sir.
Gunjan.
Thank you, Gunjan. Thank you, Pranita. And thank you, all the students.
Thank you.
Thank you, Pranita, and thank you so much, Gunjan.
Thank you, sir. Thank you.